Hi, my name is Adam, and I'll be introducing you guys to our excellent quality audit and quality audit personnel on diabetes foot complications in an inpatient setting at the Western Health Hospital, and along with the other investigators, Gergis, Mike, and Lauren Osborne. Our background information is at Western Health, and it has an above average diabetic inpatient population of around 35%. It has been estimated in previous studies that approximately 30% of these patients have an active foot condition during their admissions. It is imperative that all patients with foot complications are referred to the podiatry department within a timely manner for assessment and management of progressing foot conditions. At this point in time, we are unable to determine which patients are currently not being referred, as well as those who are referred late in their admission. This audit will involve a review of all patients admitted with diabetes at Western Health to determine the number of patients with active diabetes-related foot issues. Secondary data will be collected on referral rates and demographic data. Now, our aims of the audit is the primary objective will involve a quality audit to explore the extent of foot conditions and complications present in the diabetic foot population that is admitted to Western Health's acute inpatient wards. The benefits of conducting the quality audit in this project is to identify patients with a foot complication and prevent ongoing foot ulcerations, amputations, and readmissions from foot infections. Our participants who are identified as requiring inpatient referral to podiatry during their admission will also be provided with treatment. This may include education about accessing ongoing podiatry services and referral to an appropriate community podiatry service dependent on risk classification. By assessing a person's foot health within this cohort group and providing them with foot care strategies, we aim to ultimately reduce their risk for future foot ulcer development and subsequently lower limb amputation. Our expected deliverables and benefits for the wider community involve overall benefits of this audit to include increasing nursing staff knowledge and enhancing their understanding of when to refer patients with diabetes to the podiatry department for assessments. It also includes patients with current or potential foot complications. And by increasing their awareness and knowledge, we aim to reduce the incidence of foot ulcerations and potential lower limb infections and amputations in patients with diabetes. This will ultimately aim to decrease cost and demand on the public healthcare sector. Now, following on, our project processes involved, first of all, project scoping, which involves undertaking a literature review. We have concluded that Western Health has a high rate of admissions, particularly those with diabetes and suffering from foot complications. This may be attributed to the theory that not all staff is able to identify these complications. One way to overcome this was to develop an audit tool that will act to help determine patients' level of risk and if they're being referred to the podiatry department. Next phase is scheduling phase. During this phase, we were able to determine how each objective will be achieved along with practical tasks. By developing a Gantt chart, it enabled us to identify tasks that needed to be addressed upon completion of the audit. Tasks were delegated amongst team members with deadlines to follow up prior to commencing further tasks. And the Gantt chart was used to identify the phases within our audit and identifiable milestones. The next phase involved implementation, which through this phase we worked through our weekly goals, ensuring that the appointed team members carried out tasks in a timely manner. After weekly tasks were complete, team meetings were scheduled to evaluate the outcomes of the completed tasks. As for outcome phase, this phase assessed our overall achievements throughout this project. This helped us to reach our intended deliverables of identifying the need of podiatric referrals at Western Health.
A literature of diabetes was undertaken. Diabetes and its complication cause substantial morbidity, premature mortality, and account for a specific proportion of total health expenditure. The prevalence of diabetes mellitus in the Australian community is high and increasing rapidly. A study by Treadwell demonstrated the effectiveness of a diabetic foot disease management program in a managed care organisation. A population-based screening and treatment program for the diabetic foot can dramatically reduce hospitalisation, length of stay, and clinical outcomes. A quality audit being undertaken is a point prevalence study. This will include a foot assessment of patients with diabetes who are admitted to Footscray and Sunshine Hospital on a specified day. Patients with diabetes will be identified using hospital diet codes. The intention is to collect broad demographic and length of stay data and use this data to gather information on the current patient cohort attending Western Health Services. The principal investigator will schedule specified times at each site where they will review the IPM data system to determine how many patients are admitted with diabetes and whether they are eligible to participate in the project. The principal investigator will then approach participants who fit the criteria. A verbal explanation of the project will also take place at this time. It is at this time that the patient can decide whether they want to participate in the project or discuss any concerns in which they may have. Patients will be reassured verbally that their consent to participate is completely voluntary, and refusal to participate will not result in any discrimination or reduction in their level of care. Patients who are deemed eligible were to provide verbal consent in which they were assessed using evidence-based audit tool. Each audit will take no more than 5 minutes and will involve a basic assessment of the patient's feet. Participants will only be audited once throughout the entire length of the project, even if they are readmitted or moved to another site. Inclusion criteria includes individuals must be living with diabetes as determined by diet codes, as well as be located within the Footscray and Sunshine hospitals as part of the acute inpatient wards. Participants will also be included if English was their second language or could not speak English fluently, since the majority of Western Health patients are from non-English speaking backgrounds. Exclusion criteria include participants less than 18 years of age, those who are admitted in the emergency department, maternity, children's and subacute wards, regardless of their diabetes status, individuals with cognitive impairment or other comorbidities that may restrict them from being able to understand and provide informed consent from the audit were also excluded. Consent will be sought from all participants involved in this quality audit. A quality assurance participant information and consent form are to be completed by the participant prior to undertaking the foot screening. A participant's capacity to consent will be assessed by the principal or associate investigators, who will determine the level of language comprehension of the potential participant and cognitive ability in answering questions. A verbal explanation of the project will be provided to ensure all participants understand the audit. Assessments conducted will include dermatological, including blisters, callus, corns, current ulcer, infection, breach in skin integrity and previous amputations, as well as the presence of foot deformities, where we'll be assessing for Charcot foot deformity, bony prominences, small muscle atrophy, prominent metatarsal heads, hammer and claw toes, and limited joint mobility.
Data on patient demographics and clinical findings were recorded using data collection forms and recorded in Microsoft Excel. Patient records were used to review medical and demographic history. Data collection was de-identified using URNs and then stored securely on password-protected hospital computers. Principal investigators were responsible for the master list and maintaining confidentiality of the data collected. Records generated as a part of this project will be kept for a minimum of 7 years, consistent with the Health Records Act 2001 Victoria. After this period, hard copies of documents will be shredded and electronic files will be deleted from the Western Health server. Data was assessed on discrepancies between patients identified with a diabetes foot complication who are referred and those who are not referred to the podiatry department. Performing dermatological assessments and performing the presence of foot deformities were undertaken as a part of the audit. Due to time constraints for conducting the audit, we were unable to perform neurological and vascular assessments. These assessments will then be used to assess a patient's level of risk. We aim to ensure that all patients who are at risk or currently have diabetes foot complications are referred in a timely manner. It is shown that 92 participants gave consent to participate in the audit, with only 6 patients refusing. Consent was refused due to patients not understanding the information provided, patients not present at the time, and patients informing us that they are no longer diagnosed with diabetes. Participants all varied in the age group from 40 to 49 years of age. 32 patients were aged between 70 to 79, followed by 27 being aged 80 to 89. 19 of our patients were aged 60 to 69, 11 were aged 50 to 59, 2 were aged between 40 to 49, and finally, 1 of our patients were aged between 90 to 99. 70 of our patients' primary language was English, with 22 speaking a language other than English. As demonstrated, the most prevalent lesions affecting the participants' feet were corns and calluses, which affected 23 patients. 9 patients had a current ulceration along with the same number of previous amputations. 6 patients had non-blanching redness/infections or cellulitis. 2 patients had a rash on their feet, and finally only 1 had a blister. 71 patients had no deformities. 21 had a foot deformity that predisposes the patient to increased risk of pressure injuries, followed by 15 patients had deformities that prevented shoe wear, and finally 7 had deformities that increased risk of falls. 71 patients did not have any breaks in their skin. 11 had macerated web spaces. 3 had heel fissures, with 6 having breaks in the skin. In summary, 13% of the participants that participated within the study were currently being referred to podiatry. 27% of patients audited needed a referral to podiatry that are most at risk of severe foot deformities due to foot complications, lesions, or deformities. On paper, 27 participants were found to require referrals to podiatry, but given the fact that 2 of these only wanted their nails cut and weren't actually considered of high risk, we chose not to include them in the project.
Based on these results, we were able to make an evaluation of the project. Our short-term outcome was that all patients living with diabetes who were found to have foot complications were given referrals to podiatry to have their conditions managed. Education can also be issued to the patient regarding prevention measures. Awareness is the first step in preventing ongoing foot ulcerations, amputations, and readmission from foot infections. Our long-term outcome was that if short-term goals are successful, a reduction in the number of patients admitted to Western Health due to diabetes-related foot complications will be in place. It may also ensure a better outcome for those with complications. Numerous limitations were identified upon review of the project. It is possible that some patients diagnosed with type 2 diabetes may have been missed due to the method employed to determine suitable patients. There is a possibility in patients at Western Health have currently not yet been placed on special diet codes and hence likely to be missed while undertaking the audit. Another limitation of the project is that not all participants spoke English as their primary language. It is likely that a communication barrier between patients and staff was in place. The interpretation of foot deformities is fairly subjective. Each investigator may have different opinion on what deformities lead to falls, prevent footwear, and increase risk of ulceration. This can be overcome in future audits by the provision of a foot deformity grading tool that will eliminate subjective opinion. The grading tool may quantitatively categorize the deformities. This project also enabled us to identify a serious problem at Western Health. So we made future recommendations based on this. It was found that there are patients with diabetes, risk factors for falls and ulcerations that require referral to podiatry but have not yet been referred. Our future recommendation for the podiatry staff at Western Health would be to set up a screening process for patients who have been admitted to the hospital who have diabetes. All patients that are admitted to Western Health and living with diabetes should undergo a screening process by the podiatrist who would conduct a quick diabetes foot assessment consisting of a vascular, neurological, and dermatological assessment. If it is found that patients are at risk of ulceration, they can ensure that the correct referrals are provided. This will be aimed at preventing foot complications along with educating patients on how they can prevent foot complications. Limitations of this future recommendation include time constraints at Western Health, and they may need more podiatry staff or funding for podiatry staff to ensure that this step is taken. A way that this may be overcome is by educating nursing staff on how to perform simple assessments, as well as providing them with the knowledge in regards to what particular results mean and who the patients need to be referred to. These are our references, and thank you for watching our presentation. Hope you enjoyed it.